Okay, so let's start. Question number 1. Do you think number of the images captured infects the data accuracy? What do you think is the appropriate number of the images captured for half arch and full arch scan?
That's a really good question. And I think yes and no. I mean, the thing to realize is that when you're scanning and the more images you are capturing, the scanner is just joining those images together. It's like the first scan image you take, every subsequent scan image is connected to that. So if you sit there on the same tooth and you're constantly scanning it, it is just layering more and more images. Now, whether or not that impacts accuracy, honestly, I think the software these days is so good that unless you do something like you're scanning the same area and then some blood goes on there or the tongue gets in the way or something like that, it really shouldn't impact accuracy. But the question is, why would you scan the same area over and over? I do see a lot of newcomers to scanning. They, it's like an ironing board. They keep going back and forth, scanning the same thing. And you really don't need to do that. Once it's scanned once, that's fine. And, logic would dictate if you're just scanning the same area over and over and over, and the software is trying to keep adding these images on top of each other, it most probably can include some sort of inaccuracy. In terms of how many are the ideal images, look, I think it's just to do with time, to be honest. I have never counted the images and what's the ideal image, but I think if you're doing like a quadrant scan, you shouldn't take more than 1 minute. If you're taking 2-3 minutes and the images are going into the thousands, that's probably too much. And I think you need to refine your strategy just to make it better for yourself and for the patient. For a full arch scan, I think if you're beginning, 2 to 3 minutes is fine, 4 minutes even. But once you get experience, genuinely, you should be able to routinely do a full arch scan within 60 seconds, routinely. And I think the longer you take and the larger the scan images or the quantity of scan images, the issue is you're making the file quite large, which makes it quite annoying to save on the cloud, upload. So there's many reasons why you should try to be more efficient.
Okay. Next question, second question. When inserting a gingival cord around the implant abutment, if the gingival sulcus is too deep, the cord tends to slip down along the gingival sulcus. In such case, how do you ensure a clear margin?
That's what I was mentioning when I was talking about the implants, is that really it's not an ideal workflow to try scan an implant abutment. If I was you and the implant abutment is quite subgingival, I wouldn't even be that confident or comfortable packing cord down there, because as many of you know, with an implant, there is no connective tissue fibers directly attached to the implant. So if you are packing a lot of cord, you really risk damaging the soft tissue hemidesmosome connection, and furthermore, in putting in bacteria around the implant. So I would be very cautious with packing cord around any implant. I think a much better workflow is to use a scan body. Simply take the abutment off, put a scan body in, and then scan that. You don't need any retraction cords. You don't need anything. To just play devil's advocate, if you really, really need to scan this abutment, you don't really have any other option. Use your standard retraction techniques, laser, retraction cord, etc. But again, around implants, I would be very, very careful.
Okay. Question number 3. How do you scan when adjacent teeth are severely crowded or having large average spaces?
That's a great question. And again, something that I've seen a lot come up even in our own clinic. And I've had some really, really tricky cases where a 6 is removed, or a first molar, and the 7 is severely mesely tilted. And it becomes quite hard to get that that contact, especially if you're trying to scan for a plate or something, or even an implant. And my best advice is what I mentioned when we were talking about scanning and getting comfortable. I have my scanner here, just getting comfortable with rotation in the wrist when you're scanning. And if I have this model here, I can show what I mean is that if this is the rotated tooth, I would come from 90 degrees and rotate this direction. It takes some practice, but it really is just tackling that contact from all the different directions, not just from the occlusal and lifting the scanner up, but almost from the buccal and rotating the scanner mesially and distally to try capture that region.
Okay, thank you for sharing your tip. Okay, last question. Question number 4. Is it necessary to take pre-prepped tooth scan before cutting it out and scanning the prepped tooth? Can you go straight to the scanning the prepped tooth arch and opposing dentition?
Yeah, I mean, that's a great question. And I very seldom take a pre-op scan, to be honest. Most of the time, if you are preparing a tooth for a full coverage restoration, let's say a crown or an onlay, most of the time you either have a very large, ugly amalgam there, which you really don't want as a pre-op scan, because what is the purpose of the pre-op scan? It's to give you some data to design the final restoration. That's really the purpose of it. And for most cases, for a single coverage tooth, most good CAD software these days, such as Clinic CAD, has library teeth. So library data, or uses AI to design the crown. So you really don't need a pre-op scan. The only times where I would really take a pre-op scan is if I have a good wax up, or for whatever reason, the tooth is a very good anatomy and I want to keep it. Or more importantly, if the tooth is a abutment for a metal RPD, I would take a pre-op scan, but not of the tooth itself. I would do my preparation, I would scan that, and then I would fit the metal RPD on top of the preparation and take a pre-op scan of that, which is actually a post-op scan. Then the lab can use that scan to design the crown to fit the metal partial denture. So no, to answer your question, you don't need to take a pre-op scan for every restoration. And I actually seldom do that.
Okay. Dr. Ahmad, just one question came up in my mind. So can I ask one?
Please.
The Medit scanner has 2 light mode. One is blue light and the other one is white light. So I heard that white light is very helpful for the shiny surface scan. So have you ever tried the light?
Yeah, I think, I mean, from my understanding, the blue and white light modes were a feature of the i500. And yeah, I mean, back then when they first released it, it did help somewhat because it reduced reflection, or however way it did. I personally think rather than rely solely on the light or the software, I think clinicians, when they're scanning metals, just need to angle the scanner in different ways. When they're targeting metals to scan, they just need to use different angulations, different points of view for the scanner to scan that surface. Because whether it's white light, blue light, or any scanner on the market, I have scanned metal surfaces, metal RPDs, shiny crowns with all scanners, and they all can work without any powders or anything. Really, it just comes down to the operator and their technique to scan this surface. And I think if they believe they can scan the surface in the first place, they will find a way to do it. I think a lot of clinicians think that scanners can't scan metals, so they just give up. But the blue and white light, I think, was a release of Medit i500, and at the time, I believe it helped somewhat, but it just comes down to strategy.
Okay, thank you.
My pleasure.
Okay, so that's all about it for today. You'll be able to watch this webinar on our YouTube channel and Medit Academy once it's completed. So we would appreciate your feedback, and if you have any questions, please send us an email to meditedu@medit.com. Thank you for being here, Dr. Ahmad.
My pleasure. Thank you for having me. And as usual, it's a It's a huge honor and privilege to be on this webinar series. And I hope those of you who are listening enjoyed the episode and found it useful. Thanks a ton, guys, and have a good day or night.
Thank you for being here, Dr. Bye.
See ya.